Nós vamos ter, nós, nós vamos ter a seguinte sequência. Vamos fazer primeiro as 3 palestras, né? Como o doutor Murat não está conseguindo entrar e também não estou conseguindo contato com ele, estou até preocupado com alguma coisa que possa ter acontecido, nós vamos inverter. Eu do first your presentation, ok? Então, primeiro vai apresentar o engenheiro Tal sobre da ideia à realidade, né? Do suporte externo de aorta para demarcações similares. E depois o Dr. Conal Austin vai apresentar a técnica cirúrgica, os resultados do procedimento cirúrgico. E a seguir nós vamos apresentar os casos operados rapidamente, né, os casos operados e depois passamos então ao debate, onde eu já agradeço a aceitação do convite e a presença do Dr. Ricardo Dias, do INCOR, né, do Dr. Orlando Bender, daqui do Hospital de Clínicas da Universidade Federal do Rio Grande do Sul, a doutora Marcela Salles, do Hospital São Francisco da Santa Casa, e o doutor Eduardo Saad, também do Hospital de Clínicas da Universidade Federal do Rio Grande do Sul. Então, let's start. First of all, engineer Tom Goldsworthy, who is the first patient and the inventor of this procedure, will present his talk with from the idea to reality with PEARS.
Well, thank you, Renato. Bom dia, everyone. I'm sorry I can't speak Portuguese to do this. It'll have to be in English. I'm an engineer. I'm a chartered engineer. I'm a member of the Energy Institute and the Royal Society of Chemistry, and my background is research and development engineering in industrial combustion, which has nothing to do with medicine. I have Marfan syndrome, as you can probably see. I have the skeletal and the ocular and some of the cardiovascular manifestations, as did my father and my grandfather. In 1992, I went along to a genetic study in London, and to my horror, I discovered that my aorta was already at 4.4 centimeters, well above the normal range, and a little bit too close to the point where surgical intervention became necessary. So I went on to an annual echo regime, and as you can see, my aorta just continued to dilate as it would, until in 2000 I hit the 5 centimeter mark. That year I went down to a Marfan Association information day for patients, where Professor Tom Treasure was talking about cardiothoracic surgery for Marfan, which was essentially root replacement. So I challenged Professor Treasure and said, look, this is what we should be doing. And Tom, to his credit, opened his mind, listened, and then we built the project. So between 2000 and 2004, I put my ideas together, I put a project proposal together. Tom Treasure involved John Pepper, another cardiothoracic surgeon. I employed Imperial College with a CAD engineer, and we ran the feasibility project, which ended in May 2004 with the first device going inside me. You can see this graph stops in 2004. That's because I only graph variables. This number now is a total constant. My aorta has not changed size since 2004. This is the enlarged PEARS team. Some of you might recognize Professor Tom Treasure there. Others might recognize John Pepper. You'll probably all recognize Connell. Mike Rubens is a radiologist, and this is Peter. He's our kind of our CEO of the company, because we've now had to grow into something rather larger than the research project which I started. So this is a typical MR of a dilated Marfan aortic valve. You can see this is actually mine, but you can see it's nicely closing. So in my case, there was no aortic insufficiency, which was a nice place to start with. So that you're all absolutely sure what we protect, we go right from the aortoventricular junction at the top of the left ventricular outflow tract. We go up around the sinuses of Valsalva of the aortic valve, past the sinotubular junction, and right up the ascending aorta to very, very close to the brachiocephalic artery. This, of course, is different from a standard root replacement because you have to have room just proximal to the brachiocephalic artery to put the clamp on. so that a root replacement graft doesn't go right the way to the brachiocephalic. But it is that, it's the aortic root and the ascending aorta from the AVJ to the brachiocephalic, which we are protecting. This is all obvious stuff to you. Aortic regurgitation, I guess, is the first problem that might arise from dilation. Dissection is another significant problem, and then rupture is a very easy problem because you just send the person straight to the morgue. So there's no real surgical problem with that one. But what this does mean is that if you have a dilated aorta, as I had, and you go along every year for an echo test, it's actually very, very stressful because you don't know whether your aorta is dilated or dilated a lot or not dilated at all. And it really is a stressful experience, which you don't fully recognize until after the surgery when the stress is removed. The Laplace's law, it's lovely. I'm not a very good mathematician, but the Laplace's law is gorgeous because it shows you that blood pressure is a critical factor, aortic diameter is a critical factor, and wall thickness is also critical. Wow. And of course, as the diameter goes up, the wall tends to stretch thinner. So as your pressure goes, if you're slightly hypertensive, as I was, as your diameter goes up, then your wall thickness comes down, and the tensile load in the wall then increases. The issue of tensile load is the one we're trying to address. The compressive load.
Pessoal, tem gente com o microfone aberto. Pode desligar, por favor.
Okay. Compressive loadings on a fibrillin deficient Marfan wall probably are trivial. Bending forces are trivial. It's the tensile load, it's the stretching forces which cause a problem and which cause the potential for dissection. So the aim of my project was really very simple. I wanted to make an external support that was engineered and made to measure perfectly to fit each patient. This isn't just some off-the-shelf ad hoc wrap. This is absolutely engineered to fit each patient. And for me, the key issue was avoiding anticoagulation therapy. I was actually only offered total root replacement. I was not offered downstream root replacement. So I was very, very keen to avoid the anticoagulation therapy that would go along with a mechanical valve. So how do we do this? Well, we put our patients into a standard CT scanner. We have a standard scanning protocol, which is very easy for a decent hospital to follow. We cardiac gate into diastole. We use contrast agent to get a much better, get the best quality image of the blood we can. We go to the left ventricular outflow tract right up to the top of the arch. So these are the sorts of images that we get from the CT. We reorient the axes so that they don't lie in the parallel with the body. The orthogonal axis is not lined up with the body, it's lined up with the aortic valve. So this would be a typical transaxial image. This is actually MR, not CT. I was done with MR. I spent a lot of time in the MR scanner at the Brompton and didn't want to be irradiated by X-rays. So this is a typical transaxial view of the aortic valve. This is then a typical sagittal view. So again, you can see we're going from the aortoventricular junction up around the aortic valve to the SGJ and then right up to the brachiocephalic. So that's a nice set of orthogonal images with respect to the aorta. We then use those in a piece of software we produced in the company to produce a CAD model. This is a typical transaxial view of a patient. So you can see the CT image. You can also see two red dotted lines. These are the lines of the manufacturing former which we produce. So the outer line, which you can see there, fits the outside of the aorta. And then the inner line, which is 4 millimeters from the outer line, shows the inside of the former. And that gap between those two lines gives you a sense of scale. That's 4 millimeters. So the error there is very, very small in the fit between the CAD and the actual CT. This is a typical sagittal view, and you can see the quality of fit of the CAD to the CT is really very, very good. The tube that you can see below the aortoventricular junction, the proximal hem of our implant stops here. This tube is a tube which carries patient information, name, date of birth, hospital ID, These are absolutely bespoke, absolutely customized to each patient. So it's very important we don't put the right implant in the wrong patient. So the implant goes into the operating room on the former, and the surgeon can see and check he has the right patient. This is a little graphic showing what we're doing. We're taking a series of measurements from the aorta and we're producing this CAD model. This means that our approach is parametric rather than literal. Now, this is a typical CAD model. This one's actually my Marfan aorta. So you can see we have the patient data tube at the bottom. We have the AVJ. We then have the 3 sinuses of my tricuspid valve, the STJ, and then the ascending aorta. And we also mark the right coronary ostium and the left coronary ostium on the former. Once we have the CAD, we then use rapid prototyping to produce a solid plastic model of the aorta. And this is one you can see that will be the right coronary ostium. Yeah.
Okay.
We actually use selective laser sintering, but that's a technical issue which perhaps isn't too important. What is important is that every aorta is different. And this is just a small selection of some of the patients we've done. And you can see that pretty much there are always 3 sinuses, though we've done some bisinuate valve cases. Pretty much there are always 2 coronary ostia, though we've done patients with as few as 1 coronary and as many as 4 coronaries. And then there's an ascending aorta, but everyone is totally different. This is why they need to be customized for each and every patient. Once we've produced formers, we actually produce a couple of implants for the surgeon in case one becomes unusable. And we actually size them on diameter at 100% of 95 or 90, 85, 80, whatever it is that the surgeon wants. And you can see that the implant is a nice, soft, porous mesh, very, very porous, so that pericardial fluid can go through it, so that it can become incorporated into the adventitia. The axial seam is placed over the non-coronary sinus and runs all the way up to the top. So the surgeon is able to cut some accesses for the coronaries, cut some radial incisions through the implant, open this axial seam, and then put the implant around the aorta without transecting the aorta. In terms of the textile technology, root replacement grafts and PEARS grafts are both made using polyester, polyethylene terephthalate. They both use a multi-filament yarn, that's the thread which is used to manufacture them, but the root replacement grafts are woven and the PEARS graft is knitted. This means you have totally different mechanical properties. So that, for example, a root replacement graft is very, very stiff, where a PEARS graft is very, very soft and pliable. The edges on a root replacement graft are very hard and sharp and certainly could injure a coronary artery. On the PEARS graft, it's very, very soft and pliant, so it's very unlikely that it would injure a coronary artery. But it is important to understand that what we're talking about as a textile is totally different to what you will be familiar with root replacement grafts. I'll give you a quick cover of the surgery because that's really a job for Connell. CPB is optional. In many cases, we don't run cardiopulmonary bypass. There's no hypothermia involved, and there's no cardiac arrest normally involved. This is me actually. This is the first surgery in May 2004. So my head is at the bottom of the screen, and you can see that the implant is a very, very nice tight fit around the aorta. I think that this is a fat pad around the right coronary artery. You can see it's nice and porous, and it's a really, really good fit. It's not slack. There are no rucks or unevenness in the textile. It's a very, very tight, snug fit around the aorta. Okay, does it work? Well, this is a sagittal view of me in 2004. This is one in 2014. I don't bother changing this picture anymore because the picture just stays the same. Given the limitations of getting a patient in the seat in the MR scanner in the same position and getting the imaging plane identical, I think you'd agree that, that this ascending aorta is pretty much identical to this one. In fact, I have an annual MR and there are no measurable changes in my aortic size at any aortic dimension over the 18 years that I've had it in. One of our patients died of an unrelated cause 3.5 years after surgery, and there was a post-mortem examination because he was a young lad in his 30s. And they took a sample, a histological sample, through his aorta within the graft. So this is here the outside of the adventitia. This is neovascularization, I am told, in the neoadventitia. And this is the graft fully incorporated. So we now have a new composite material, a textile reinforced living tissue neoadventitia, which is going to be significantly stronger than the adventitia it left. This is the media, which is delaminated from the adventitia during the sampling process. The other interesting aspect of this particular PM was that the media, when looked at, has a completely normal appearance. So it's still fibrillin deficient, but because the systolic, diastolic, repetitive strain has been removed from it, it's able to recover and to heal to some degree, such that it has the appearance of normal media. This must significantly reduce the risk of dissection within this media. Okay, so in terms of the number of the patients that we've done now, this is a couple behind because Renato and Conal have done another couple. So we're at 586 patients, mostly men, more men than women. We've got a cumulative total now of over 1,700 post-op patient years, which is a significant number, I would say. There are 29 of us with more than 10 years, and now nearly 100 of us with 5 years of post-op experience. Our youngest patient was a 3-year-old, which Conal did. She had an adult-sized aortic valve. We would not put this in a child with a child-sized anatomy. We would only put it around an adult-sized anatomy. Our oldest patient is a 76-year-old lady in the Czech Republic who had a standard aortic PEARS. But you can see the vast majority of cases we're doing are teenagers, 20-something, 30-something. I guess that this kind of number set would reflect the age of death for people like me before surgery became possible. Most of our cases are still Marfan syndrome. About our first, I think probably our first 80 or 90 cases were all Marfan. But we have now moved into a variety of other aortopathies and other cases. Quite a few Loeys-Dietz, quite a few BAV cases. Interestingly, about 20 of these are bisinuate BAV cases, which struck me as particularly interesting given how rare bisinuate BAV is. A lot of idiopathic people, a lot of idiopathic cases, which is great for them. Conal will tell you more, but he's done a number of cases of patients who've had the aortic switch operation, and also patients who've had a standard freestanding root Ross where the autograft is dilated significantly. We've been able to put an undersized PEARS graft on to bring the pulmonary autograft down in size, to bring the valve leaflets back together and recover dilation. And then finally, and this is really one of Conal's innovations, we're able to scan and model from the pulmonary valve prior to a freestanding root Ross operation, make an implant to fit the pulmonary valve, move it from the pulmonary position to sitting on top of the left ventricular outflow tract, put the PEARS around it, and we're getting some great results with that. So this is a way of solving. This is a way of solving the problems of dilation, autograft dilation, in the freestanding root Ross. Okay, so in terms of the aortic PEARS, we've now done 534 cases on an intention to treat basis, with 521 cases completed. We've had a number of conversions for reasons, intraoperative conversions. We've also had one perioperative mortality. 1 in 532 is much less than 0.2%. We've also had, from relatively early patients, we've had some redo operations where during the learning curve of putting the device on, we didn't quite get things right, but all of those patients are fine. They've been reoperated on and brought up. The Ross PEARS, I'll leave Conal to talk about, but again, we've done 68 on an intention to treat, completed 64, a couple of conversions and reversions, and one peri-op mortality. So, 1.6% is bad news for the person involved, but it's still a relatively tidy statistic. This is the only perioperative aortic case we lost. This guy had a very bad pectus excavatum. This gap between his sternum and his spine was so small it was barely possible to get your finger into the gap. He had an injury to his left coronary main stem. He went into myocardial stunning. They put him onto cardiopulmonary bypass. They put a suture in his left main stem. They put a cabbage around the damaged left main stem. They switched him onto ECMO. Day 2, no improvement. Day 3, no improvement. Day 4, he started to show signs of recovering. They were going to wean him off the ECMO on day 5 to fit the device, but on the night of day 4, he had an intracranial bleed from which he didn't recover. So it was not a device-related death, but it was certainly a surgical-related death, probably as a result of his extreme form of Marfan syndrome. This is the comparison table which I present to various people. I note that if PEARS was not available and I had only been offered valve sparing or total root replacement, this would have been a very hard decision, because the reoperation rate for Bentall is quite a bit lower than valve sparing root replacement, but you've got to have anticoagulation. That's something I really didn't want. When I look at this now, I mean, for me, this is a complete no-brainer. I would want a short operation. I would want CPB to be optional. I would want to have a really good fallback position. So as a patient, not as a surgeon, as a patient, I look at that table and I just say, it's obvious, PEARS is where I want to go. Of course, I'm not the person who has to do that dissection, that posterior dissection below the left coronary main stem without injuring it. And that is, I think, quite a difficult, quite a stressful thing to do. But from a simple patient perspective, it's obvious that it would be PEARS that I would want. It took us 13 years to do the first 100 patients, 22 months to do the second 100 patients, 11 months to do the third, I think 11 months to do the fourth, and 6 months to do the fifth. But you can see that this really is taking off now. And in fact, COVID slowed us down a little bit, but we caught up from that. We actually did 167 operations last year in 30 centres. So things really are going well in terms of patient numbers. This is a rough list of the centres. So we've got a number in the UK, a couple in Ireland. We've got many centres in the Czech Republic. They've really bought into this in a big way in the Czech Republic. And in fact, the second largest centre, beyond Connell, I think, has done over 200 operations. The second largest surgeon is one of our surgeons in Australia, in Melbourne. He's done over 80 PEARS operations now. So about 10 countries, about 30 different surgical centres. I think the reason that we've got to such a good result in such a short time is because of our multidisciplinary team. I think that has really helped us. We had surgeons, cardiologists, engineers, and that really gave us a very high-speed route, so relatively cheap as well as relatively fast, to a great result. And I'm living proof of that great result. Nearly 18 years and everything working fine. I would argue that we have a technically superior solution to total last-minute root replacement, in as much as you have a short operation and you're not reliant on drugs. I suspect many of our patients will have their PEARS operation, they'll go home, and they'll never have to come back to the hospital. They will come back for an annual MRI, but they don't really need to come back. I'm sure that patient operative stress is reduced. If you have a 2-hour procedure off pump versus maybe a 7-hour procedure on pump, you've got to be feeling better afterwards. You don't feel very good even after a short operation, but this has to be good. But perhaps the most important issue here is a really reduced lifetime healthcare cost. Many of us are living longer, the population is getting bigger, money is tight, it's very tough. We need to get better treatments at a lower cost in order that we can all access healthcare. A lot of acknowledgements to make to various people. I suppose if I could pick out two, it would be Tom Treasure and John Pepper. Tom opened the door to the medical world for me, and listened and helped me build the project. John Pepper did the first 24 operations under great pressure from some of his less generous colleagues, and the rest is history. If you can access the Extent website, and I know there have been some problems in Brazil with the website being blocked, there's a lot of information on there. If you can't access it, then please get in touch with Renato and get in touch with me, and then I can email you any of the information that you would like about the project. Thank you very much.
Okay, thank you very much, Tom, for a very nice and brilliant presentation. Nós temos já a presença do professor Murat na sala, então nós vamos passar a apresentação dele. Bem-vindo, professor Henrique Murat. Eu fiz as apresentações iniciais, por uma dificuldade técnica, nós invertemos as apresentações, então a sua apresentação agora será sobre o tratamento estándar atual, padrão atual do aneurisma da aorta ascendente, né? Pode compartilhar a tela e entrar, por favor.
Tá compartilhando? Bom dia.
Tá ótimo, estamos vendo e ouvindo bem.
Está vendo bem?
Sim, sim.
A tela está compartilhada?
A tela está tela cheia, tudo normal.
Bom, agradeço o convite. Eu acho que depois desse espetacular resultado mostrado, eu acho que eu tinha que mudar esse título para tratamento atual convencional dos aneurismas da aorta ascendente. Bom, o que a gente... O aneurisma de aorta ascendente, a aorta ascendente, você pode contar como um todo, você tem a raiz da aorta, e tem o anel aórtico, o seio valsalvo, a junção sinotubular, a aorta ascendente e a arco aórtico. A maioria mais da metade dos aneurismas de aorta ascendente da porção tubular, eles se estendem ou para a aorta distal ou para a aorta proximal. A indicação cirúrgica, ela se dá nos sintomáticos, e nos assintomáticos ela depende do diâmetro aórtico, da progressão da dilatação, da genética do paciente e de fatores de risco. E o que a gente objetiva, tanto nos doentes sintomáticos quanto nos assintomáticos, é tratar ou evitar ruptura, dissecção de aorta e insuficiência aórtica. Na aorta ascendente, o diâmetro, quando a gente utilizar o diâmetro, os protocolos utilizam o diâmetro 5,5, porque a partir de 6 existe uma incidência muito maior de complicação, seja por dissecção, ou seja por ruptura. A probabilidade de dissecção da aorta ela é maior na porção tubular. Então, na porção tubular, a partir de 5,5, esse trabalho de Wojnarski, ela, a partir de 5,5, aumenta muito a probabilidade de dissecção, e o mesmo não ocorre no seio de valsalva. Essa probabilidade ela é mais linear, ela é menos acentuada. Isso que muitas vezes a gente deixa um seio de valsalva, e isso pode não ser tão catastrófico quanto a gente pensava alguns anos atrás. Em termos de crescimento da aorta ascendente, ela é proporcional, é maior nos grandes aneurismas. Um aneurisma pequeno, de 3,5, 4, ele vai crescer 0,12 centímetros por ano. Já um aneurisma que tenha 8 centímetros, ele vai crescer 0,25 centímetros por ano. Então, o aneurisma grande tende a crescer mais e precisa ser operado mais rápido. Em termos de indicação, nós tentamos cada vez mais ter um padrão genético para indicação cirúrgica. O aneurisma de aorta torácica é monogênico. Atualmente são 31 genes que são estudados. E a gente sabe hoje que algumas dessas alterações genéticas, como a gente encontra no Loeys-Dietz síndrome e na Ehlers-Danlos ou no síndrome de Marfan, obrigam a operar esses doentes com diâmetros menores de aorta, 4 a 4,5 para o síndrome de Loeys-Dietz e menor que 5, 4,5, 5 para os doentes com síndrome de Marfan e herpes. Alguns outros genes, sejam eles do músculo liso ou do padrão TGF, também indicam a necessidade de cirurgia mais precoce. Eu acho que dentro de algum tempo a gente vai estudar mais geneticamente esses doentes para saber aqueles que a gente deve operar mais precocemente. Em termos de fatores de risco para dissecção ou ruptura de aorta, algumas coisas são importantes. A primeira delas, eu acho que é a história familiar. Cada vez mais, a gente, examinando os doentes, conversando com os doentes na primeira consulta, já deve procurar saber a história familiar. Uma história familiar é um potente fator de risco para que um aneurisma disseque ou rompa. Um aumento maior do que 3 milímetros por ano, uma insuficiência aórtica importante, que obriga a operar pela insuficiência aórtica, gravidez ou desejo de gravidez, por causa do aumento de dissecção de aorta nesses aneurismas com pacientes grávidas, e se for válvula aórtica bicúspide, coartação de aorta ou hipertensão arterial. O guia usado atualmente ainda é o guia de 2014, a diretriz de 2014 da Sociedade Europeia de Cardiologia, é o mais usado com alguns updates. Então, em termos de indicação cirúrgica para o aneurisma de aorta ascendente, se o paciente não tem elastopatia, essa indicação a gente opera esses doentes acima de 5,5 milímetros, de 55 milímetros de aorta ascendente. Essa é uma indicação 2A dessa diretriz europeia. Se for síndrome de Marfan, acima de 5 centímetros, é uma indicação 1. Se for síndrome de Marfan com aqueles fatores de risco que eu mencionei, a gente usa 4,5 centímetros, tendo a indicação 2A. E na válvula bicúspide e fatores de risco, usa-se 5 milímetros, que é uma indicação 2A. Diâmetros menores podem ser considerados em algumas situações, como, por exemplo, baixa estatura, progressão rápida do aneurisma, insuficiência aórtica importante, gravidez planejada ou até mesmo preferência do paciente, sendo indicações de 2B. Só para falar, recentemente, é um trabalho do grupo do professor Eleftheriades, em que mostra que a gente sempre se guiou pela superfície corporal, mas a altura apenas, eu acho que é suficiente para se fazer um risco de estimativa de aneurisma de aorta ascendente, principalmente porque a superfície corporal varia ao longo da vida do paciente. Então, aqui, por exemplo, uma paciente que tenha 1,40 m e tem 4,5 centímetros de aorta ascendente, o risco dela... Aqui, essas cores aqui estão meio erradas. Devia ser o verde aqui como risco baixo, amarelo como risco moderado e vermelho como risco pior. Mas dentro dessas cores a gente pode ver que se uma mulher de 1,40 m tem um aneurisma de 4,5 centímetros, ela é considerada de alto risco, ou seja, ela tem uma chance de mais de 12% por ano de sofrer dissecção ou ruptura. Com esse mesmo 4,5 centímetros, se você tem 1,85 m, o seu risco é muito baixo, inferior a 4% por ano. Então, a altura tem que ser muito bem valorizada na avaliação pré-operatória desses doentes. Mas as coisas nem sempre são assim. Esse aqui é um doente desse trabalho que mostra que ele vinha com 45, aí foi aumentando devagarzinho ao longo dos anos. Um ano antes estava com 51 milímetros, aí dissecou, e foi para 58 milímetros. Então, a tendência em locais onde a mortalidade é baixa, de se operar esses doentes com diâmetros menores, doentes sem elastopatias. Aqui nesse trabalho da Universidade de Yale, com 780 pacientes, eles operaram doentes acima de 5 centímetros, a cirurgia profilática foi recomendada, e quando ela foi feita, o risco de mortalidade de 30 dias foi de 1%, e, por outro lado, o risco de morte e acidente aórtico foi bastante elevado, com risco de morte de 12%. E dentro das doenças aórticas, um outro capítulo à parte é o capítulo dos pacientes com válvula aórtica bicúspide. E esse aqui é um sumário Só diminuir aqui. Que é a válvula aórtica bicúspide, que ela pode, a aorta ascendente na válvula aórtica bicúspide, ela pode dilatar somente a porção tubular, pode dilatar a absorção tubular e a raiz da aorta, ou pode dilatar a aorta ascendente, pode dilatar toda a raiz da aorta. A recomendação para tratamento da ressecção aórtica no paciente com válvula aórtica bicúspide é com diâmetro de 5,5 centímetros, classe 1. O paciente 5 centímetros com fator de risco, como foi dito anteriormente, que é 2A, e 5 centímetros mesmo com baixo risco, e mesmo sem fatores de risco, pode ser operado, deve ser operado em centros especializados que têm um baixo risco. Isso é considerado 2B. E aqueles pacientes que vão ser submetidos à troca valvular aórtica, a diâmetro de 4,5 centímetros já indicam uma cirurgia. Se você for operar um doente para uma troca de válvula aórtica e o paciente tem um aneurisma de 4,5 centímetros, essa aorta deve ser ressecada. Isso já faz parte do guideline de manuseio de doença valvular aórtica, agora em 2020, da American College of Cardiology e American Heart Association. Algumas coisas são particulares também para você indicar a ressecção aórtica num paciente que tenha uma válvula que vai ser submetido a uma troca valvular com válvula aórtica bicúspide. O diâmetro de 4,5 centímetros, como nós falamos anteriormente, uma aorta muito alongada, muito fina. Essas aortas que são de espessura muito pequena têm uma maior incidência de dissecção a médio prazo. Então, essas duas possibilidades, eu acho que merecem ressecção de aorta. Pacientes mais jovens podem ser considerados, porque provavelmente essa aorta vai ter problemas com o tempo. Se for implantar uma válvula mecânica, por probabilidade de uso de anticoagulantes, também vale a pena também operar em diâmetros menores. E se tiver alguma aortopatia, tipo uma ultrapatia, elastopatia. Nessa evolução do Michael Borger, ele acompanhou doentes que tinham ou menos de 4 milímetros, entre 4 e 4 milímetros e 4,5 milímetros para cima, operados de troca valvular aórtica. E ele observou que os doentes que menos de 4 milímetros, a sobrevida em 15 anos foi muito pouco afetada pela ortopatia. Nos pacientes acima de 4,5 milímetros, a sobrevida, e a sobrevida também tem sobrevida sem operação aórtica, ela foi bem menor do que a dos outros. Então, justifica, sim, que pacientes que vão ser submetidos à troca valvular aórtica e têm uma aneurisma de aorta ascendente acima de 4,5 centímetros, eles devem ser submetidos à ressecção da aorta. Quanto aos aneurismas 4 a 4,5, isso ainda é um ponto de interrogação, porque a evolução deles há 15 anos foi muito boa, com pouca operação. Esse trabalho é um trabalho interessante, está no Journal Annals of Thoracic Surgery, ainda aguardando publicação, em que pegou pacientes com válvula aórtica bicúspide que tinham a aorta proximal dilatada, incluindo a raiz e a aorta ascendente, e fizeram troca valvular aórtica. E compararam dois grupos. Um grupo que tinha dilatação proximal da aorta e um grupo que não tinha dilatação proximal da aorta. Esse grupo de 431 pacientes, eles foram feitos só a troca valvular aórtica. Um grupo tinha a aorta dilatada, entre 4 e 4,5, e outro grupo, que é o grupo controle, tinha uma aorta de 4 centímetros. E eles notaram que, ao longo de 10 anos, não houve diferença, que o PEARS 0,2, entre o grupo que tinha a aorta proximal dilatada entre 4 e 4,5 e o grupo que não tinha essa aorta dilatada, a de aorta era menor do que 4 centímetros. Então, aí eles concluem que uma aorta com diâmetro proximal entre 4 e 4,5 pode ser deixada sem tratamento ao se fazer a troca valvular aórtica em pacientes com válvula aórtica bicúspide. Outro trabalho interessante também, agora ainda está na fase de publicação no Journal of Cardiovascular Surgery, que é o destino a longo prazo da aorta após ou envelopamento, wrapping, ou troca da aorta ascendente em pacientes com troca valvular aórtica. É um grupo da Coreia do Sul. Eles operaram 964 doentes de 1995 a 2018, dos quais 204 tinham aorta entre 4 e 4,5 centímetros, 108 perseguições da aorta e 96 envelopamentos. E o que eles encontraram? A mortalidade foi baixa, em torno de 2%, e aí eles conseguiram fazer um matching, né, uma propensão de 70 doentes com envelopamento aórtico e 70 doentes com troca valvular aórtica. Em termos de sobrevida, foi igual. A única coisa que eles notaram é que havia um crescimento maior da aorta no grupo do wrapping em relação ao grupo da troca. Esse grupo aqui cresceu 0,34 milímetros por ano, enquanto o grupo da troca cresceu 0,06 milímetros por ano. Com isso, a mensagem que eles deixam é que o envelopamento aórtico e ressecção da aorta ascendente neste paciente com aorta entre 4 e 4,5 centímetros, elas são duas opções que podem ser usadas quando o paciente é submetido a troca valvular aórtica. A dilatação pós-envelopamento aórtico necessita de monitorização. E eu deixo uma pergunta, se realmente precisa fazer essas coisas. Aí, como a gente opera no livro da aorta ascendente? Alguns cuidados só de cirurgia que eu acho que vale a pena tocar. Primeiro, eco transofágico em todos os pacientes. Normalmente, colocamos pressão arterial em ambos os braços, pela eventualidade de ser necessário hipotermia profunda e parada circulatória total. Temperatura é 32 graus, podemos ser necessário hipotermia. Cardioplegia pode ser anterol ou retrógrada, sanguínea, com custodiol ou deonido. Quando o paciente tem a aorta, pela tomografia, uma aorta doente, uma aorta com placa, a gente tem usado ultrassom epiaórtico. E o acesso arterial, na maioria dos doentes, é pelo arco aórtico, em alguns por subclave, iluminada, axilar, carótida e muito raramente femoral. Uma coisa que eu queria deixar assim, que é importante, é estar preparado sempre para fazer a anastomose distal aberta, porque é menos lesivo para o doente se fazer uma anastomose distal aberta do que uma anastomose que você bota uma pinça na aorta, que pode ser curta, difícil de suturar, e que pode esmagar alguma placa e promover embolia cerebral. Em termos de resultado cirúrgico, essa aqui é uma avaliação. O resultado aqui no Brasil é muito bom, a maioria tem um resultado bastante baixo. Esse aqui é o banco de dados da STS. Entre 2011 e 2016, quase 53.500 ressecções de aneurisma de aorta ascendente, e 1.045 centros, a mortalidade global foi de 3,2%, sendo de 2,2% em casos eletivos. O tratamento da aorta ascendente por endoprótese, aqui nós temos um trabalho do Eduardo Saad, da Ana Paula e do Cui Almeida, ele ainda está pouco utilizado, quase sempre para doentes que não podem ser submetidos à ressecção cirúrgica. Esse aqui é um outro caso publicado de uma endocardite de aorta ascendente, com vários furos na aorta, e uma colocação de uma endoprótese com um bom resultado. Tem sempre muita dificuldade de critério do tamanho da aorta, da distância das coronárias, da distância da artéria nominal. Mas é uma possibilidade que começa a surgir, mas ainda é ocasional. Era mais ou menos isso que eu tinha que falar sobre o tratamento atual do aneurisma de aorta ascendente. Eu acho que o tipo de prótese que se usa tem pouco impacto sobre o resultado cirúrgico. Aqui no Brasil, nós usamos muito mais prótese biológica do que se usa na Europa e nos Estados Unidos, e o resultado é quase sempre muito bom. Como estamos numa época um tanto quanto traumática, essa frase do Pablo Neruda, que foi o Prêmio Nobel da Paz, de Literatura, poeta chileno, que foi morto durante a ditadura chilena, eles diz que poderão cortar todas as flores, mas não poderão deter a primavera jamais. Muito obrigado. Ok. Ali você está sem microfone.
Desculpe. Então, vou repetir aqui. Obrigado, professor Henrique Murado, pela brilhante, completa, atual, excelente apresentação, que nos coloca bem atualizado sobre o tratamento da aorta ascendente convencional, como você falou, né? E também com uma visão sobre o endovascular. Nós vamos passar agora para a apresentação do Dr. Conal Austin sobre o suporte externo personalizado, indicações, técnicas e resultados.
Good morning. Thank you very much indeed. What a fabulous discussion to follow on from Enrique there. Thank you very much indeed. I've learned a lot, even if some of it was lost in translation. So I hope that you will understand my Irish accent, and I will proceed to tell you about my experience really with an evolving technique of PEARS. The picture here shows the hospital I work in. The bright light here on the right is the Evelina Children's Hospital, because I primarily am a pediatric, or was a pediatric heart surgeon, but I've adopted a lot of new techniques for the application of PEARS to aortopathies. So I've got no financial interest to declare. I always start these talks by really paying tribute to my colleague, Mr. Tal Goldsworthy, who's sitting beside me here. It's really quite unique to have a patient who can be so focused to develop an operation that he wanted applied to himself, but also to have the determination and grit to actually see this right through to almost nearly 600 patients having a PEARS prosthesis done 18 years after his was performed. So it's a pleasure to work with him. So why did Tal not want conventional cardiac surgery? Now, all these operations like a Bentall procedure and valve sparing root replacements are very important operations, and they should be in every cardiac surgical's armamentarium. I myself perform Bentalls and valve sparing root replacements, but they do have drawbacks. The mechanical Bentall, the BioBentall have the drawbacks of the mechanical and the biological heart valve. And the valve sparing root replacement, more commonly nowadays, is performed with the Tyrone-David operation, but that operation itself has been through many iterations because of the complications of the operation and the problems with long-term aortic valve insufficiency. But nevertheless, very good operation. So in this meta-analysis, the things that probably were concerning Mr. Goldsworthy and many other patients and clinicians would be the relative ongoing risks to the patient on an annual basis following the Bentall and the valve sparing root replacement. Thromboembolic problems are more problematic when the aortic valve is replaced, but you can see that the reintervention rate for valve sparing root replacements from 11 publications in this meta-analysis by Benedetto and Tackenberg demonstrates that there's a significant year-on-year valve sparing root replacement intervention problem. And when you add and summate these complications, there's really no statistical difference between a Bentall and a valve sparing root replacement in terms of long-term complications. And we're talking about lots of very young patients here having congenital aortopathies or congenital cardiac operations, such as my adult congenital population. So we've seen already from Enrique's talk that the major determinant in dissection would be the aortic root size. However, dissection can occur at diameters that are smaller than the international cutoff for root replacement. And again, that was shown in Enrique's study. This is an immensely stressful period for people who have got aortopathies and the Marfan's patients who are attending for annual review, waiting for the aorta to get to the size that would dictate that they undergo aortic root replacement. This is a rather old study now, but it looks at patients' ascending aortas, and you can see that below the threshold line of 5 centimeters, there's still a significant proportion of patients that will dissect with their aorta between 4 and 5 centimeters, and even below 4 centimeters. And in a more recent paper in the European Journal from 2019, they followed up 117 Marfan's patients with CMR. In that period of time of the study, 13 patients underwent elective root replacement, but 4 patients developed an acute aortic dissection, 3 of which were type A. And of these 3 patients, none of these patients had actually met the criteria for elective aortic root replacement. So Marfan's patients are highly motivated patients, and nowadays we're living in a very communicative world with Facebook, internet, etc. And these are highly motivated patients, and the patients that we're operating on in Porto Alegre on this visit have all actually decided this was the operation that they want, and they've approached Dr. Khalil to do this surgery. These patients generally present a bit earlier with genetic testing nowadays. So if you get an acute aortic dissection, has that been a failure of our diagnosis, our surveillance, or our decision making? Tal has already shown these, so I'm going to skip through them, but essentially this is what the graft looks like. It's expanded polyethylene, and it's a woven graft. And when you hand this graft to a cardiac surgeon for the first time, they go, oh, that's quite nice, it's soft, it's compliant. So this is the PEARS flow chart that shows what happens when the clinician decides that one of his patients wants to develop a PEARS flow chart for surgery. The first thing is that the patient undergoes a CT scan. The CT scan is then sent to the extent company. The extent company then will send that back by email to the surgeon. The surgeon will look at it, assess the aortic dimensions, and see whether that's suitable for valve for PEARS PEARS manufacture. The extent company then manufacture a solid pro forma, and on the solid pro forma is woven the mesh, and then this is ready and sterilized and sent out to the surgeon for implantation. Now this gives a small sample of some of my patients that I've been involved in, and really my study at home has got many, many more. My wife's fed up looking at them sitting all around the house. Tal has shown you these images, so there's no need to show them, but what's important for the cardiac surgeon is to carefully analyze the data that's sent back to you from the extent company, and you want to look at the coronary arteries, one for the number of coronary arteries, the position, location, and you can see here in this anterior coronary artery, the right coronary artery, that there's an accessory infundibular or conal branch. Also, this patient has got a relatively short left main stem, which can make dissecting around the left main stem a bit more tricky. And we all know that sometimes the circumflex and the left and the LAD can come off via separate osteons from the left sinus of Valsalva. Quick example of what a conal artery looks like that I had to deal with a number of years ago. Now, this is from our recent paper produced by Louise Kenny, one of the trainees in Brisbane when I was out operating in Australia with to do congenital cardiac cases and younger patients. And this has just recently been published at the JCTBS. So these are wonderful anatomical diagrams. To do this operation, it's through conventional median sternotomy. The anaesthetist will prepare the patient such that they may need to go on to cardiopulmonary bypass. A circuit should be set up in theatre, but not primed with fluid, so it can be used for other patients. And usually, for the vast majority of aortopathies, in most of the PEARS surgeons experience, the operation can be done off cardiopulmonary bypass, unless you're doing a concomitant procedure. So tracts and sutures are placed in the aortic root. The right coronary artery is dissected out underneath, fully right down to the ventricular arterial junction. And we use the model, the PEARS graft, as a bit of a roadmap to give you the location of the coronary artery and the depth to which you have to dissect into the right ventricular outflow tract to get to the ventricular arterial junction. So you've got to go with that maximal convexity of the sinus of Valsalva. Again, we're continuing the dissection on down towards the left coronary artery and over the non-coronary sinus of Valsalva over the roof of the left atrium. Then some radial stellate incisions are made in the graft. We don't excise a disc of the PEARS material because we want to keep that material so that it forms a nice little button around the coronary artery, but with the tissue supporting the ostium of the coronary artery, so you don't get late aneurysm formations as you can in Bentall procedures. Radial incisions are then made from the longitudinal axial seam out to these stellate incisions. And then this produces a coronary artery tab shown here at point A, which is then brought underneath the right coronary artery. And similarly, the tab B, which is the left coronary artery tab, is brought underneath the left coronary artery, the left main stem. And the two are then approximated with very strong suture being placed at the annular hem. The annular hem suture is very, very important. And then the longitudinal axial seam is closed all the way up to the brachiocephalic trunk. And further sutures are then used to close the radial incisions out to the ostiums of the right and the left coronary artery. Care is then taken to check the ostiums that they're not impinged or slightly constricted, and that could be visualized by the transesophageal echocardiography, which is mandatory for all of these operations, looking at valve function, aortic sinus valsalva, dimensions, non-aliasing of flow into the left and right coronary arteries, and no obsession to the regional wall motion. This is a short video which just shows the operative diagrams, but actually in an operation. And this is a patient. It's difficult to see the aneurysm, but it all hides underneath the right ventricular outflow tract, as is seen by my fist here. First of all, I use the graft as a route map to where the coronary arteries are and the distance that you have to dissect under the coronary artery. With tracts and sutures, you can lift the aorta backwards and forwards, and you've got to work very closely with your anesthetist to keep the blood pressure. I've just demonstrated the left main stem and the right coronary artery, and then measuring the distance of the dissection over the right sinus of valsalva to the ventricular arterial junction. Now we're creating the little stellate cuts for both the right and the left coronary artery, and we want to retain that tissue, so that tissue sort of folds around the ostium of both the right and the left coronary arteries. This is the left coronary button, coronary artery, around the back of the aorta, and this one's quite difficult to see when you're having to lift the aorta, but keeping the blood pressure at about 60, 55 millimeters of mercury, the aorta becomes as soft as compliant as it is when you're on cardiopulmonary bypass. Now we're creating the radial incision for the longitudinal axial seam for both the left and the right coronary artery tabs. We put some paraffin on it so that the coronary artery tabs are slightly lubricated so they don't snare and snag when being placed under the right and left coronary arteries. And now we're demonstrating the folding nature of the left coronary artery tab so that it's placed underneath the left main stem, which is denoted just down there by a blue silastic slope. This is then recovered around the posterior aspect of the aorta and brought out towards the anterior aspect of the aorta where it'll meet the right coronary artery tab, which is then brought underneath the right coronary artery. And then the annular hem will be reconstructed with a very strong suture of ticron with multiple knots so that it doesn't ever become loose or fall apart. And then the longitudinal axial seam is closed all the way up to the brachiocephalic trunk. And this is being denoted by these sutures, bringing all the PEARS prosthesis back together again after the radial incisions. Once this is completed, then you close the radial incision out to that, in this case, the right coronary artery. And this really is the finished product. And here we're demonstrating complete coverage of the ascending aorta over the maximal convexity of the sinus of Valsalva underneath that right coronary artery, and similarly under the left main stem for a distance of about 1 to 2 centimeters, right down to the ventricular arterial junction. And then it's completely covered posteriorly, and I'm demonstrating the left coronary artery coming out through the PEARS, and complete coverage of the non-coronary cusp sign of Valsalva, and the longitudinal axial seam is closed right up to the level of the brachiocephalic trunk. And in a few cases, I've actually continued the graft right round to the left subclavian. This is Tal's aorta, and we've already seen that. So I'm going to skip through that. So what about the results? Well, I've done quite a number of these operations, both at St. Thomas's Hospital and internationally. So we decided to look at the first 100 patients that I performed at St. Thomas's Hospital. And this has just been accepted, the AATS, for the meeting in Boston in May.
Nesse caso, liberar o nosso funcionário, fazendo por aqui, libera os hóspedes coronários. Isso.
Thank you. So we decided to look at the underlying diagnosis, the operation that has been performed, and then the follow-up of the patients. So our results are going to be measured overall by the maximal dimensions of the intraoperative echocardiogram, the presence and degree of preoperative and postoperative aortic valve regurgitation, and obviously clinical outcomes such as death or adverse related events. Our patients at St. Thomas's Hospital are very carefully followed up with an annual MRI at the time of the anniversary of the first operation, and thereafter every 2 years. Intermittently, they will get echoes as dictated. So this is an easy number because I've done 100 patients, so therefore everything is easy to calculate in terms of percentages. But half of the patients that I've operated on have got a simple dilatational aortopathy, like Marfan's disease or Loeys-Dietz syndrome. 10% of the patients had a bicuspid aortic valvotomy, but with a fully functional aortic valve or maybe just mild aortic valve insufficiency. 7% had congenital cardiac operations to Tralegy Fallow or post-arterial switch. And then a new operation that we've been developing really is the free root Ross supported with a computer-generated PEARS to fit the autograft in the aortic position. And interestingly, some patients that have had a previous free root Ross who developed the dreaded complication of Ross dilatation can be recovered with the reduction PEARS. 24 of my patients were less than 18 years of age. So the operations that we performed would be isolated PEARS procedure or PEARS with a concomitant mitral valve repair. Sometimes the PEARS have been performed with other congenital procedures such as repair of a cone operation for Epstein's disease of the aortic valve. And in a few patients, we have done reduction aortoplasties and then calculated a PEARS graft to be manufactured on the size of the aorta that I would envisage the aorta to be after the reduction aortoplasty. We've done 29 Ross operations, Ross PEARS operations, 5 of which have been left ventricular outflow tract enlargements, and 2 patients who have had autograft dilatational recovery. This demonstrates for the first group the more simple types of aortopathy, the overall reduction in size that we can achieve by placing a reduced size PEARS. Usually the reduction in size for a simple or more straightforward PEARS operations would be 0.8 of a centimetre. But sometimes I've brought the aorta down from 6.2 to about 4.6, as I might show later on if I've got time, to recovery severe aortic valve regurgitation. And this is one of the things that we've been noticing as you have applied the aortic graft at a reduced size, you get a higher increased coaptive area between the aortic valve leaflets, and you can get quite marked reduction in central 3-leaflet aortic valve regurgitation by applying a surgically reduced PEARS prosthesis. We've had one early death. This was in a 63-year-old lady who underwent concomitant Epstein's repair. But I don't really think in any way that the PEARS had anything to do with the death. She died from right heart failure. We've unfortunately one late death, a gentleman in his late 60s who died in the first wave of the COVID pandemic. All the patients are extensively followed up and there has been no progressional aortic dilatation, and nor have we had any coronary artery injuries. And if you've read our recent 200 patient experience, we have had a 5% incidence of coronary artery injuries. And I think that really reflects the difficulty in learning this operation and the fact that you do need to be proctored very carefully over a period of about 6 different operations before you get fully comfortable with dissecting out the right and left coronary arteries. We've had 3 late aortic valve replacements, 2 of them in my early Ross PEARS patients, and 1 patient after an arterial switch operation where the aortic valve needed to be replaced. So in conclusion, the PEARS can be used for a wide range of dilatational aortopathies. We've proven that it's a safe operation which in simple aortopathies can be performed off cardiopulmonary bypass. Application of a reduced size PEARS can control or obliterate central 3-leaflet aortic regurgitation. With our increased experience of PEARS in Marfan's patients, I've gone on to develop the Ross PEARS operation with with a graft that is manufactured to the size of the pulmonary artery, which is then transferred across to the aortic position. We have a meticulous follow-up for all of our patients at St. Thomas's Hospital. So when I joined the project in 2012, the only operations with PEARS have been for Marfan's patients. So these were patients who had an ascending aorta, and the PEARS graft was made to be absolutely morphologically compliant to the size of the aorta. And that has been now subgrouped into PEARS 1 and 2, because some of the patients have got dilatations of the neo-aorta following arterial switch operations or other congenital procedures, and also dilatations following the Ross operation. We then have a PEARS 2 group, which is the so-called Ross PEARS, and that's an anatomically adaptive operation because we're manufacturing a PEARS graft based on the size of the pulmonary artery in the pulmonary artery position from the CT scan preoperatively, but we're also augmenting the posterior sinus of Valsalva to resemble the two anterior sinuses of Valsalva in the pulmonary artery position. And then the third operation is one anatomically corrective. So if you've got a very dilated sinus of Valsalva that might be compressing a coronary artery, that sinus of Valsalva can be reduced in size, and a PEARS that is anatomically corrective can be manufactured to the size of the aorta that the surgeon envisages the aorta to look like once the reduction in size of the aorta has been performed. And we've got several examples of that. These are two patients, father and son, who got operated on the same day with Marfan's disease. And they were both done off cardiopulmonary bypass. And the young fellow is a mountaineer and real outward bounds exponent. He's sailed the Atlantic. He's kayaking all over the world, and he's very, very active. These are two identical twins who 9 years ago had a PEARS applied off pump for concerning valve aortopathy that the cardiologists were excited about because they were rapidly enlarging. They had fully functional aortic valves, and 9 years later, they're very stable with no change to their aortic valve function. This is a young girl from Colombia who came to London 3 years ago for a PEARS operation. Her mother, to her right, had a mechanical ventral done at the Cleveland Clinic when she was 18, and she had 2 strokes, and her family were very keen to explore other ways going forward. I'm not sure if I've got any more time, or should I stop?
Yeah, so a few more
minutes. So some interesting cases. I'll give you an example of a child that I operated on who was a baby with double outlet right ventricle. I initially banded that baby, and then 3 years later, I performed an arterial switch operation. 8 years later, my cardiologist got quite excited because the child had classical symptoms for angina pectoris, and an MRI scan showed a very eccentric dilatation of the anterior sinus of Valsalva, which was compressing the coronary artery. And this, following arterial switch operation, has actually been quite well recognized. And our own department had a very sad demise of a young girl who was exercising with a very similar type of anatomy. This shows the dilated sinus of Valsalva with the LAD coming off anteriorly. So I met with Tal and the company, and I said, I want to excise this sinus of Valsalva, and I want to make a PEARS that will reflect the size of the aorta after it has been excised. And this is really what we did. We sat down with a computerized model. We can see the 2 coronary arteries marked on the green former. And it demonstrates the size of the aorta after we had excised this very large anterior sinus of Valsalva. And then this is the actual former, rotating it to show that there's an absence of that very dilated sinus of Valsalva. And I'll go on to show you how it looked at the time of operation. So an operation, redo surgery. This is the LAD, which is stretched underneath the right angle probe, the very large dilated sinus of Valsalva. I then cut the holes for the grafts, open up the PEARS prosthesis, and that's what it looked like before I applied the PEARS. And after the aortic reductions surgery and the application of the PEARS, you can see quite clearly that there's free air underneath the left anterior descending coronary artery, and it looks like a bit like a bucket handle. And this child has remained symptom-free for angina for many years. Some of my cardiac surgeons have asked me, can you do PEARS for other complicated cases, such as patients who have got very severe renal disease? So we had 2 patients. One was a Jehovah's Witness awaiting a kidney transplant with a 5.2 centimeter aorta, And in him, I was able to perform off-pump PEARS application. And one was a 38-year-old postman who had a fully functional renal transplant with an ascending aorta of 5.5, and his cardiac surgeons were afraid of the impact of cardiopulmonary bypass on his functioning renal transplant, and he also underwent off-pump cardiac surgery to apply a PEARS to his entire ascending aorta. As I've mentioned before, aortic valve insufficiency can be recovered by reduced size PEARS, and I'll show an extreme case. This doesn't really show up some of the PEARS surgeons in a very good light, because this PEARS surgeon decided to apply the PEARS graft. They obviously bottled out and didn't put the graft underneath the coronary arteries. In fact, he cut the hem off the graft. And not surprisingly, the unsupported portions of the aorta dilated from 5.2 centimeters to over 6 centimeters in a short 3-year period. And his mild AI, which had been present at the time of his 5.2 centimeter aorta, increased to severe AI. I consented the patient for a ventral procedure because I didn't think it would be possible to apply a further PEARS to his aorta, but nevertheless, we did manufacture a further PEARS based on a reduced size of his 5.2 centimeter aorta. And I was able to do this operation of cardiopulmonary bypass and put a second PEARS over the non-covered portions of his ascending aorta. This shows the severely dilated 6 centimeter aortic root with severe aortic valve insufficiency, both the longitudinal and the axial projections. And this is the post-operative images showing the reduction from 6 centimeters down to 4.6 centimeters with a dramatic reduction in AI. And this was performed 3 years ago. We've seen similar things with the free root Ross, where we've recovered AI in those patients who've got dilated aortic valve insufficiency. Again, one of my patients who had an interrupted aortic arch had been repaired, followed by subaortic stenosis, small left ventricular outflow tract, underwent a free root Ross, Koner Ross operation, and 3 years later ended up with this massively dilated aortic root with AI. Here we can see the dilated aortic root. The AI was relatively trivial through the central portion of the 3-leaflet aortic valve. Then I performed an 80% reduction PEARS off bypass, and the AI is virtually abolished. So, thank you.
Okay, thank you very much. Very brilliant presentation, Conal. And now we will present. Could you share the?
Yes, of course.
Now we will present rapidly 2 cases that were operated yesterday. Eu gostaria de pedir então para a doutora Marisa coordenar a apresentação rápida dos 2 casos operados ontem, os aspectos principais dos casos e a evolução deles, e em seguida avançamos ao debate também. Ok, Marisa?
Certo, então, bom dia para as pessoas que entraram depois. Nós tivemos ontem 2 casos bem ilustrativos, um caso com e outro sem extracorpore, e quem vai nos apresentar os casos é o Dr. Eduardo e o Dr. Zatti, nossos residentes de 5º ano, e nós temos também esses casos registrados com ecocardiograma pelo Dr. Diogo. Então, acho que o Eduardo pode começar, Eduardo.
Ok, já estão me ouvindo?
Sim, sim.
Sim, tá, vamos compartilhar a tela aqui. Certo, então eu sou o Eduardo, residente do Instituto de Cardiologia, 5º ano. O primeiro paciente é um paciente do sexo masculino, 33 anos, um paciente com uma história de síndrome de Marfan, devido à história familiar presente do pai, então ele já tinha um acompanhamento desde os 5 anos de idade. Ele, previamente isso, ele passou por um procedimento de correção do descolamento de retina, estava usando enalapril e bisoprolol. A dilatação da aorta começou em 2013, então ele começou a fazer, até 2013 estava praticamente em dimensões normais, a partir de 2013 começou com dilatação, ele começou a acompanhar mais regularmente. Em 2016, ele teve a indicação cirúrgica para a correção do aneurisma já. Portanto, ele não ficou muito satisfeito com as indicações e o próprio paciente resolveu procurar outros métodos cirúrgicos, enfim, para a patologia dele. De exames, então, a gente tem um eco transtorácico, que junto com o aneurisma de raiz de aorta, mostrou um prolapso de válvula mitral, principalmente do folheto posterior, com uma insuficiência moderada. A angiotomografia confirmava o aneurisma, enfim, dimensões semelhantes ao eco, 5,4 centímetros, e já a junção sinotubular de dimensões normais. Como tinha essa insuficiência moderada, a gente solicitou pelo eco transtorácico, solicitamos um eco transesofágico, que mostrou realmente o prolapso da válvula mitral de ambos os folhetos, mas principalmente do folheto posterior. No entanto, a regurgitação, a insuficiência mitral era severa em vez de moderada. E confirmou também esse aneurisma de 5 centímetros na raiz da aorta. A imagem da tomografia, então, a gente pode ver os seios de Valsalva, a dilatação dos seios e da raiz da aorta, até mais ou menos a junção sinotubular. O diâmetro de 5,4 na tomografia, na raiz da aorta, a via de saída de uma dimensão normal, e já a junção sinotubular acima de diâmetros normais. O ecocardiograma, de novo, a medida da raiz da aorta pelo ecocardio, na junção tubular ascendente, a válvula aórtica era três folhetos aqui, tricúspide, e não apresenta insuficiência. E as dimensões da via de saída sistólicas e diastólicas do ventrículo. A princípio era isso o caso.
Bom, o paciente foi à cirurgia ontem e o Dr. Diogo fez o acompanhamento da cirurgia com o ecocardiograma transesofágico. Acho que o Dr. Diogo pode nos relatar alguma coisa do transoperatório através da ecografia.
Olá, boa noite, bom dia a todos. Compartilhar minha tela aqui. Então, conseguindo me ver?
Sim.
Aqui travou um pouquinho meu computador, só um segundinho aqui.
Bom, enquanto isso, só que foi decidido, né, já mesmo com a insuficiência mitral moderada, já se tinha ideia de que esse paciente deveria fazer correção da válvula mitral, né, então ele foi preparado então para fazer o tratamento preconizado, que a gente está discutindo, mais o tratamento da válvula mitral. Ok, pode continuar.
Tá, então só vou dar continuidade à apresentação. Eu sou o Diogo Centenário, sou anestesista do SANI, tenho um fellow em anestesia cardiovascular e torácica em Toronto. Só para ilustrar, eu trabalhei 2 anos com o Dr. David lá em Toronto e eu queria ver se ele está com esse sorriso no rosto dele, conhecendo a personalidade dele, se com essas novas técnicas aí, com tão bons resultados, né, se ele estaria tão feliz assim. Na verdade, conhecendo ele, eu acho que ele não estaria tão sorridente. Só algumas considerações sobre o eco transesofágico nessa cirurgia.
Não está mudando o slide, está só no primeiro.
Ah, tá. Mudou agora?
Sim, sim.
Tá, então esse é a fotinha que eu mostrei do Dr. David. Não sei se ele vai estar com esse sorriso aqui, com essas novas técnicas. Então, algumas considerações sobre eco transesofágico, né? Nessa cirurgia que foi passado pela equipe cirúrgica, que nós, primeiro caso aqui nas Américas, então não tinha muita experiência de o que avaliar, né, no transoperatório. Então, primeiro checar o fluxo nas coronárias estavam normais, o funcionamento correto da válvula aórtica, né, alguma deficiência de contração, contratilidade do ventrículo depois do implante da válvula, caso tenha cometido algum ósteo coronariano, e comparar o tamanho da raiz da aorta antes e depois do implante da prótese. Então, esse primeiro caso é um paciente, eu troquei aqui, esse aqui eu achei que ia ser o primeiro caso, paciente de 33 anos, né? Na verdade não é esse aqui é o paciente do segundo caso. Nós começamos com linhas invasivas, né? Nós já sabíamos que ia entrar em SEC, uma anestesia, né? Sempre mirando uma distribuição precoce, com controle da pressão arterial, principalmente na hora da dissecção ali da aorta ascendente e o implante da prótese. Tem que o recomendado pela equipe seria uma pressão sistólica de no máximo 70, então entre algo em torno de 50 e 70, e dispositivos para monitorização da função cerebral, ou com NIRS, né, que é a saturação cerebral, ou com o BIS mesmo, também para poder indicar algum hipofluxo caso a hipotensão tivesse alguma repercussão hemodinâmica da oxigenação cerebral. Então, o primeiro caso, esse paciente de 33 anos com uma síndrome de Marfan, como foi apresentado, né, insuficiência mitral severa e dilatação da raiz da aorta, função histórica normal e sem comorbidades significativas. Então, só para ilustrar aqui, uma cirurgia que entrou em circulação extracorpórea e para fazer um reparo da válvula mitral, que teve uma duração de em torno de 5 horas e 15 minutos, né? Isso aqui é super estimado, porque geralmente a gente coloca pelo menos uma meia hora a mais na ficha anestésica, então em torno de 4 horas e meia, 4 horas e 45, com tempo de circulação extracorpórea em torno de 72 minutos e campeamento de 64 minutos, com uma perda sanguínea de 300 ml e um balanço hídrico positivo de 1000. Mostrando que só a período de um pouco de mais de hipotensão aqui logo após a SEC, né? E pré-SEC, onde eles dilataram, onde eles dissecaram, né, a raiz da aorta, e pós-SEC enquanto estavam implantando a prótese. Esse aqui é o primeiro slide do raiz da aorta, aqui no seio de salva, né, um diâmetro de 4,7, na ressonância e na tomografia eram maiores, né? Aqui mostrando, tentando em 4 câmeras, a anatomia um pouco distorcida devido à dilatação da aorta ascendente, mas com função ventricular normal aqui nas paredes anterolateral e infraseptal. Aqui 2 câmeras mostrando também a parede anterior bem, né? Aqui a coronária circunflexa desobstruída. Eixo longo mostrando a parede anteroseptal também contraindo bem. Aqui já mostra um folheto da válvula mitral anterior já espessado, né? Já com essa... Nós tínhamos um diagnóstico prévio de uma doença mitral tipo Barlow, assim, com bastante acometimento da válvula mitral, mas que não foi bem exatamente o que a gente achou no transoperatório. Tinha alguns segmentos do folheto posterior que estavam prolapsando, né? Mas o anterior não estava tão ruim, então acho que a expressão da doença mixomatosa não era tão avançada para caracterizar um Barlow. Então, se tinha uma expressão de que o reparo ia ser muito difícil, mas que eu acredito que foi bem factível. Aqui o eixo curto do ventrículo esquerdo no transgástrico, né, mostrando então uma boa contratilidade global do ventrículo, sem nenhum déficit sistólico de contratilidade. Aqui a válvula mitral, mais a 1P1, a 2P2, uma válvula mixomatosa com certeza, mas também a implantação do folheto posterior não é tão distorcida, né? E não tem tantos segmentos prolapsando, o folheto anterior não prolapsa tanto, né? Aqui mostrando já um pouco mais anteromedial da válvula, mais P3 e A3, mostrando que aqui já tem um pouquinho de prolapso do folheto posterior. Aqui já bem a P3, mostrando o prolapso importante do folheto posterior. Esse aqui é o jato de regurgitação com uma vena contracta de 0,7. Era um jato bem na final da sístole, né? Uma vena contracta já caracterizando insuficiência mitral severa, mas era um jato bem efêmero, ele acontecia só no final da sístole, então às vezes difícil de caracterizar, né? Aqui mostrando que é um jato curto, né? Mas com uma vena contracta grande. Aqui mostrando um pouco também do A2P2 no eixo longo da válvula aórtica. Esse de novo, a vena contracta de 0,8, caracterizando então também uma insuficiência mitral severa. Aqui a válvula aórtica, então funcionando bem, né? Com a boa coaptação, os folhetos abrindo bem, mas o seio de valsalva bem dilatado. a raiz da aorta, o ânus da aorta não era um ânus dilatado. 2,9 foi medido e a via de saída de 2,6, aqui de novo 4,8, talvez um pouco subestimado, e o STJ. A aorta ascendente de 2,8, ou seja, o acometimento mais mesmo na raiz da aorta, uma válvula aórtica tricúspide. Aqui é a válvula tricúspide, tudo certo, sem regurgitação tricúspide importante, sem forameval patente, um septo interatrial normal. Aqui é a parte mais apical do ventrículo, também contração normal. Blunting da onda S nas veias pulmonares, né, caracterizando então uma sístole mitral moderada, mas pela vena contracta e pela característica do jato a gente caracterizou como severo. Tentando achar o ósseo da coronária, que é uma coisa importante, aqui a coronária esquerda, se nós observarmos aqui junto ao folheto coronariano esquerdo, essa porção mais escura aqui é o tronco da coronária esquerda, um tronco curto, né? E aqui é a subdivisão em circunflexa e descendente anterior, que é importante para nós acompanharmos no pós se tem fluxo no Doppler, né? Então a aorta descendente sem dilatações, sem dissecções, e o arco aórtico também livre de qualquer patologia. Então pós-SEC, né? Então a plastia mitral, foi feita a ressecção quadrangular do segmento P2, uma anuloplastia na anatomia do P2 e depois o implante de um anel Carpentier. Bom, não sei exatamente qual é o nome, o tipo do anel, mas depois podem ser explicado. Então, uma avaliação da mitral sem regurgitação, anatomia aqui, o folheto posterior paradinho, o anterior fazendo toda a função, sem regurgitação também mais profundo no P2. Aqui já uma normalização uma equalização pelo menos das ondas das vias pulmonares, mais um pouquinho da anatomia do reparo. Então aqui sem nenhuma regurgitação, de novo só escaneando a válvula. Aqui uma anatomia sem, dá para ver aqui o anel, né, nos dois lados da válvula mitral, sem nenhuma regurgitação aqui também. Vou passar um pouquinho, mostrando então que o reparo foi bem sucedido, né, apesar da anatomia da válvula ser um pouquinho mais difícil pelos 2 ou 3 segmentos que estavam prolapsando. Aqui o gradiente transvalvar de 1,9, gradiente médio. E aqui pós-implante então da prótese na aorta ascendente, né, então pós-SEC e pós-graft. A válvula aórtica com mobilidade preservada, né, que já se nota um pouco a redução do diâmetro da raiz da aorta, sem insuficiência, ou seja, mas talvez mínima, né, mostrando um funcionamento normal da válvula pós-implante da prótese. Um ano, aqui essa parte ela ficou um pouco acima do ânus da aorta, ela ficou mais reduziu mais, né, foi para 2,9, que um pouquinho acima, ou seja, é uma apertadinha um pouquinho acima do ânus da válvula. E aqui já no seio de valsalva, um diâmetro de 4,4, não reduziu muito, mas a equipe cirúrgica estava feliz com o resultado. Aqui então mostrando o ósseo coronariano livre aqui de novo, né? Aqui o tronco da coronária esquerda, e aqui a coronária direita com o Doppler aqui nessa parte mais anterior da válvula aórtica, e mostrando aqui a contratilidade preservada do ventrículo pós o implante da válvula. Esse caso era isso.
Obrigada, Diogo. Então, acho que a gente apresenta o segundo caso, o Dr. Zatti vai nos apresentar. Aí, este paciente já é um paciente que não entrou extracorpórea e só foi feito o tratamento da aorta. Pode apresentar, Zatti.
Tá bem, bom dia a todos. Vou passar minha tela aqui. Todos conseguem ver a minha tela?
Sim.
Então, tá, bom dia a todos. Meu nome é Fernando Zatti, sou R5 do Serviço de Cirurgia Cardíaca do Instituto de Cardiologia. apresentar o segundo caso aí. Então, é o MVF, 41 anos, um homem, utilização de medicação era somente a losartana. Então, é um paciente que ele já acompanha no Instituto de Cardiologia desde os 7 anos de idade, quando ele começou a fazer alguns exames e fez um ecocardio que apresentou um aumento da aorta, da raiz da aorta, né, de 2,7 aí. Desde então, ele começou a fazer alguns acompanhamentos anualmente, né, com ecocardiogramas, assim, até 98, e teve aí um tempo que ele ficou afastado sem fazer exames, né? Então, em 2012, depois de um teste de esforço, ele foi diagnosticado com hipertensão e começou a ser feito tratamento clínico. Entre 2013 e 2017, ele também se perdeu um pouco nos follow-ups aí, e voltou em 2019 ele se manteve assintomático, e voltou em 2019 para mostrar alguns exames, né, sem apresentar a regurgitação da válvula aórtica. Conversando com a equipe cirúrgica e clínica, foi avaliadas diferentes técnicas para intervenção do aneurisma da aorta e do Marfan. Então, ele começou a pesquisar essas formas de intervenção e se interessou pelo PEARS, né? Ali por 2019, por julho de 2019. Enquanto, então, ele ficou aguardando aí o procedimento, ele foi fazendo algumas tomografias de controle. De história familiar, ele não apresenta nenhum histórico de aneurisma de aorta, morte súbita ou cardiopatia isquêmica. As cirurgias prévias dele foram feitas, então, por 3 vezes, cirurgia de varizes bilateral e uma fasectomia, que ele teve uma subluxação da lente. A alergia, ele tem a amoxicilina, que teve um caso de prurido. Então, aqui a primeira tomografia que ele fez em 2017, né, então apresenta aí a raiz da aorta ali, apresenta um diâmetro de 4,5 por 4,5 e na junção sinotubular de 3,9,39. Aqui algumas imagens da tomografia de 2017, mostrando aqui mais ou menos. E aqui é a comparação em 2020, foi o comparativo com a que ele tinha, vendo que teve um aumento nas dimensões da raiz da aorta para 4,8 por 4,8. Demais tamanhos e segmentos da aorta não apresentaram alteração nos seus diâmetros. Então, aqui, a tomografia de 2020, aqui apresentando, então, os diâmetros, mostrando que teve um aumento nesta região. Aqui reconstrução mais próxima, aqui mostrando as distâncias entre os ossos das coronárias. O ecocardio transtorácico, então, aí um paciente de 1,96 m, 90 kg, sem alterações nas válvulas mitral e aórtica, e também tanto na pulmonar e na tricúspide. Estão mostrando que realmente teve um aumento na raiz da aorta. Então, mostrando que foi realmente teve esse aumento ali, sem a presença de regurgitação da válvula aórtica e da mitral. Fez também uma cintilografia, tá, que mostra que o miocárdio tem uma perfusão normal, sem evidências de isquemia miocárdica, né? A fração de ejeção é normal também, sendo 58 em repouso e 56 após o estresse do exercício. Aqui tem aqui as imagens da cirurgia, né? Aqui na primeira imagem, o esovasc aqui sendo preparado. Aqui, no momento em que estão começando a realizar o implante, aqui a imagem do processo final aí, como ficou o aspecto da cirurgia. Era isso.
Certo, então acho que a gente pode seguir com a apresentação da eco. Só uma colocação, a válvula aórtica não tinha assim nenhuma alteração significativa, mas tinha aquela insuficiência aórtica mínima, que normalmente é descrita, mínima ou leve. E a cintilografia foi indicada porque esse paciente já tinha mais de 40 anos, mas não tinha nenhum histórico compatível com doença isquêmica. Acho que a gente pode continuar com a eco, Diogo.
Tá bem. Estão vendo o meu slide, tudo certo? Então, segundo caso, então, esse paciente de 41 anos estão com uma síndrome de Marfan, dilatação da aorta ascendente, com uma insuficiência aórtica leve, com função ventricular normal e sem comorbidades significativas. Só mostrando então a duração do procedimento em torno de 4 horas, menos, na real, na verdade, a gente superestima que esse tempo deve, entre 10h30 e 11 horas nós já estávamos fora já estava tudo pronto. O paciente foi estubado em sala, que um período de hipotensão, né, durante a dissecção e o clampeamento e o implante da válvula. E o paciente foi estubado, tranquilo, para a sala de recuperação. Então aqui a aorta ascendente, aqui no nível um pouquinho acima do seio do ânus da aorta, de um diâmetro de 4,8, essa aqui é a veia cava superior, aqui é a aorta ascendente. Aqui é 4 câmaras, também 5 câmaras na verdade, mostrando a parede anteroseptal e a parede anterolateral aqui contraindo bem. 2 câmaras, então avaliação pré-implante da contratilidade, parede anterior e parede inferior, todas as duas com contração preservada. Aqui o eixo longo da válvula aórtica, a parede anteroseptal, contratilidade preservada. Outra clipe desse mesmo. Aqui um foco então na válvula mitral, com folhetos normais, né, coaptando bem, com uma boa área de coaptação. O seio de valsalva dilatado, o ânus da aorta não estava dilatado, né? 2,7 anos, 2,6 de via de saída. E de novo aqui um clipe da válvula aórtica funcionando. Aqui o seio de valsalva medindo 4,7, 4,8. A STJ 4,1. E a aorta ascendente, o nível da pulmonar direita de 13,5. Aqui mostrando a insuficiência leve, né, da válvula aórtica. Aqui outro clipe mostrando então esse jato, um jato pequeno, né, com uma vena contracta de 0,2, caracterizando a insuficiência aórtica leve. Aqui um pouquinho da válvula mitral, que dizia ter uma insuficiência mitral leve, tem um jato bem precoce aqui na sístole, mas é um jato pequeno, realmente leve no máximo. A válvula tricúspide, um pouquinho de prolapso, mas nada demais. Ventrículo direito contraindo bem, a válvula aórtica tricúspide. E aqui um bicaval mostrando um septo interatrial íntegro e o resto tudo normal. Aqui a contratilidade mais basal no eixo curto do ventrículo esquerdo, todos os segmentos preservados, com contratilidade preservada. Aqui já mais segmento médio, nos 2 papilares também contratilidade preservada, isso tudo pré-implante da válvula. E aqui já mais apical também, com todos os segmentos do ventrículo contraindo bem. E a aorta descendente, então sem nenhuma patologia, sem nenhuma dilatação ou dissecção. E pós-implante, então, uma redução do seio de valsalva de 4,8 para 13,8. E desaparecimento daquele jato de regurgitação aórtica, então o paciente saiu sem regurgitação aórtica que ele tinha, a válvula tricúspide aqui mostrando, abrindo bem, sem restrições e sem nenhum jato central que era evidenciado pré-implante da válvula. E aqui a contratilidade global também preservada. De novo, duas câmaras aqui, parede anterior contraindo muito bem, parede inferior sem déficits sistólicos de contratilidade. Aqui é o intraceptal também. Eixo curto do ventrículo esquerdo, todos os segmentos contraindo bem. E aqui só uma comparação do eixo duas câmaras transgástrico e o eixo curto mais apical. E todas as paredes sem nenhuma déficit de contratilidade. A cirurgia é muito tranquila, né?
E Diogo, obrigado.
Obrigada, Diogo. Eu só queria fazer uma consideração do pré-operatório desses pacientes, né? Então, são pacientes muito diferenciados, que eles que procuraram o tratamento, e um paciente que já tinha uma indicação cirúrgica e um paciente que foi procurar um tratamento profilático. Então, agora eu peço para o Dr. Calil coordenar a discussão dos cirurgiões.
Certo, obrigado, Marisa, obrigado pelas apresentações. Então, entre os nossos debatedores convidados, a gente tem a honra de ouvir agora as opiniões, comentários e debates sobre esse assunto. Eu vou passar a palavra primeiro ao Dr. Ricardo Ribeiro Dias, do INCOR de São Paulo, que é um cirurgião de referência em São Paulo para aneurismas de aorta e complicações de aneurismas de aorta, né, Ricardo? Então, a gente tem a honra de tê-lo aqui hoje para comentar esse trabalho.
Professor Renato, muito obrigado pelo convite. Eu inicio cumprimentando a todos pela oportunidade de estarmos juntos. Queria cumprimentar o Dr. Murad pela apresentação, o Dr. Tal Golesworth também pela sua apresentação, o Dr. Conal Austin pela apresentação e por estar aqui nos ensinando, né, a fazer esse tipo de procedimento. Parabéns pelas cirurgias, né, os resultados muito bacanas, casos complexos, cirurgia nova. A minha grande preocupação, e que é o comentário e que justificaria o fato de eu nunca ter me entusiasmado muito por essas técnicas de wrapping, diferente da situação como o Dr. Austin colocou como uma possibilidade de suporte para o ROS, para evitar a dilatação, aí sim me parece uma técnica muito interessante. Por que eu faço esse questionamento? Porque quando nós temos a formação do aneurisma de aorta, nós já temos estabelecidas alterações morfológicas na parede da aorta extremamente significativas, né? Então, nós já temos, para nós termos um aneurisma de aorta, nós já temos toda uma fragmentação da elastina, uma alteração do colágeno, uma hiperatividade das metaloproteinases, nós temos as interleucinas inflamatórias da parede da aorta muito alteradas, nós temos já alterações estabelecidas de microRNA, nós temos apoptose na parede da célula, e então isso quer dizer que o tecido as proteínas que compõem as paredes, as camadas da parede da aorta já estão muito alteradas. Então, é claro que o conceito físico do aumento da espessura da parede da aorta para conferir maior resistência e evitar a sua comparação é fascinante, né? Mas a minha grande preocupação é que nós temos já um substrato anatômico muito comprometido. Então, no longo prazo, apesar dos resultados mostrados já com mais de 500 pacientes, um resultado muito bacana, né, que foi apresentado pelo Dr. Tal Golesworth, me preocupa muito isso, porque a doença na parede da aorta, ela não muda, né? A alteração estrutural da célula já está estabelecida. E esse procedimento não confere essa alteração. Esse tipo de preocupação física só, né, que realmente justifica muito, me lembra um pouquinho a ideia do professor Batista quando ele fez a cirurgia dele de reconstrução ventricular, né? uma vez que você diminui o diâmetro, você diminui a tensão na parede, então se esperava um tipo de resultado. Porém, as células já estavam muito comprometidas e, infelizmente, deixou de ser uma opção cirúrgica interessante depois de algum tempo de segmento. Claro que aqui nós já temos um tempo de segmento bastante estabelecido, mas me preocupa um pouco esse tipo de conceito, porque nós, claro, não temos como estudar como fica a parede da aorta, a não ser naquele caso que faleceu por outra causa, né? Mas, poxa, se nós não temos uma reversão de toda a alteração da parede da aorta, que é uma alteração muito importante da média, já muito comprovada, por que esse procedimento tem uma longevidade garantida, né? Essa que é a minha preocupação em relação a essas técnicas de wrapping, que já teve uma experiência na aorta abdominal, claro que com outro tipo de material, no começo do século passado, não tinha nem nascido, né? Então, não sei exatamente como foi esse desenvolvimento, mas me preocupa um pouco em função disso. Seriam essas as minhas colocações.
Senhor Ricardo, gostaria de fazer essa questão para ele em inglês ou eu posso transmitir aqui? Você acha melhor?
Não, pode. Se você quiser traduzir, por favor. Se quiser que eu tente, eu posso tentar também.
No, I will try to convey the question. It's this is the wrapping of the aorta, but the aorta is also already damaged by structurally and biochemically and histologically destroyed. She is worried about the long-term fate of this aorta. Besides the results that you have presented in the long term, she is worried about this. How you do in the long term?
I think the concerns have been raised before by lots of surgeons, and I think the only way you can really answer that question is by the number of patient years that have been observed in the follow-up of nearly 600 patients who have had PEARS for different reasons. I think there's 1,750 patient years of follow-up, and there have not been any dissections in the ascending aorta. So, Ricardo, when do you expect the aorta to dissect? Well, I would expect the aorta to dissect in systole. So if you've got an aorta that even is diseased, don't forget we've just seen a histological slide to show that the cystic medial necrosis actually can potentially heal itself in the covered portion of the of the PEARS supported Marfan's aortic root. And the aorta tends to tear when it's in systole. It doesn't tear in diastole, that just doesn't happen. So the tear occurs when the aorta expands. So if the aorta doesn't expand, because one, it's healed by the PEARS prosthesis, and two, that it's constrained in size, I think that's perfect proof that the graft will not dissect, plus the fact that it hasn't happened to our notification in any patient that's had the operation performed.
Okay. Are you satisfied, Ricardo?
Oh, yeah, yes, sure. It's a good point. But another question would be, I don't know exactly the majority of the diameters of the patients that you have been treated, but okay. I imagine that if you deal with patients with aortas over 5 centimeters or 6 centimeters in general, do you think you can have the same result than with patients 4 or 4.5?
It's a good question, actually, and it's something that's actually very interesting. I actually advocate this procedure almost as a prophylactic procedure, so that it should be put on to patients with smaller aortas. One, it's technically much easier to operate an aorta that's 4 centimeters as opposed to an aorta that's over 6 centimeters. When the project started, we decided to have an upper limit of 5.5 centimeters as being the size that we would not implant a graft beyond. But over a while, that has changed. And I have certainly done patients with an aorta over 6 centimeters, as I've shown you one of the examples of 6.2. And there have been several like that. I've done an Olympic athlete at 6.2, 6.3 centimeters with an idiopathic aortopathy. I've done a young boy who had a Marfan's aortic root of 5.2. And by the time he came in for cardiac surgery due to different cancellations, it was 9 months later. And his aorta was 6.2 centimeters and really ready to rupture. That one scared the wits out of me, and I really thought I was going to have to do a valve spray route in him. But in fact, with very careful hypotensive anesthesia from anesthetist, we were able to do an off-pump PEARS in that patient, and that patient's been done about 6 years ago. And so I agree that, you know, I think where would my cutoff be? I really wouldn't want to be doing too many aortas bigger than 6.5 centimeters, but I've got some pictures which I showed with Dr. Khalil yesterday of a young patient with an aorta that just looked ripe for rupture. It was over 6 centimeters. And in that patient, I did a reduction ascending aortoplasty because he had a bicuspid aortic valve, which was fully functional. And then I was able to put a PEARS on it, which I had calculated to a reduced size based on experience of doing reduction aortoplasties. And Tal's company made me up a graft that was essentially 4 centimeters as opposed to 6 centimeters plus. It's a good question. I think there's no hiding from the fact that PEARS is here to stay. It's actually, sometimes it's not demanded by clinicians, it's being demanded by patients. These patients, as I said, are very vocal. They're looking up the internet, they're chatting to each other on Facebook and on Marfan's websites. Duke Cameron, I think, has actually done a 180 degrees turn. He's now actually quite a proponent for the PEARS procedure. He's come to London. He's watched me do this operation. He's looked at my bag of 60 plus odd prostheses that I handed to him, and he was delighted to see that I was placing grafts onto ladies who wanted to get pregnant before their aorta got to 4 centimeters. I think by the time you get to 6 centimeters, either the patient is a de novo mutation you are not aware of, but if you're sitting there watching your patient get to beyond 5 centimeters with a Marfan's aortic root, I don't really think you're doing the patient a service. But it's, you know, the project's evolving. 167 patients done in a 12-month period shows that, you know, the genie is out of the bottle here, and patients are demanding it. And the patients that we have come to operate on Porto Alegre have actually asked for this operation to be done. It's been done through Dr. Khalil, but at the behest very much of the patients. And I've done many American patients, European patients who do not have this operation available to them in their home countries. And I take my hat off to those patients who decide to take their own initiative for the management of their cardiac condition. And they look at the results, they read the papers, they're all out there in the journals, and they make a calculated decision themselves to come forward for this type of cardiac surgery.
This is an example of a bicuspid patient we did in New Zealand, and this guy's aorta is, I think, 5.8 centimeters, very big. He had an off-pump procedure, I think, about 5 years ago, and he's completely okay. When I look at that as an engineer, and I see how the device becomes completely incorporated into the adventitia to form a neo-textile reinforced soft tissue composite sheath around the aorta, I then realized that must take the tensile loadings off the intima and the media, and therefore the chance of this guy dissecting, it is not zero. I accept it is not zero, but it's very, very small, particularly if you put an undersized graft on. So time will tell. But I mean, I go along to the Brompton Hospital every year for an MRI, and every year my aorta is dimensionally identical and looking healthy and no dissections. I think if we were going to have seen a dissection, we would have seen it by now. We have 29 of us with more than 10 years follow-up. I'm the most at nearly 18 years follow-up, and we haven't seen a dissection. I'm sure it's correct to be worried about a dissection, but I think we need to look at the evidence. The evidence is it hasn't happened.
Ok. Estou pouco preocupado com o avanço do horário aqui. Nós temos ainda que ouvir a doutora Marcela, os comentários. A doutora Marcela é cirurgiã cardiovascular do Hospital São Francisco, da Santa Casa da Misericórdia de Porto Alegre, e nós temos o prazer de tê-la aqui presente para ouvir seus comentários.
Bom dia a todos. Eu agradeço o convite para participar.
Sim.
Estão me ouvindo? Eu agradeço muito o convite do Dr. Calil para participar dessa sessão e aproveito para parabenizar o Instituto de Cardiologia daqui de Porto Alegre, que sempre nos traz novas tecnologias e nos coloca up to date. Parabéns, Dr. Calil e grupo. Não vou repetir os comentários que o Ricardo já fez da aorta, mas tem assim 2 pontos que eu gostaria de levantar, que da bibliografia, mas eu gostaria de ouvir pessoalmente os colegas convidados, né? Que é em relação aos ensaios clínicos randomizados. Tem uma publicação que cita várias justificativas para que a gente não tenha ensaios clínicos randomizados, comparando essa tecnologia com o tratamento clínico, porque a gente sabe que um tratamento clínico otimizado, controle muito rigoroso desse paciente, a gente pode manter ele em observação por muito tempo, né? E também comparando este procedimento com a cirurgia precoce, né? Então, assim, não existe, não tem publicação de nenhum trial randomizado, e eu gostaria de ouvir, então, a impressão de vocês. E outra questão seria em relação aos pacientes com válvula aórtica bicúspide e com dilatação da aorta. O exostent, ele protege a aorta, mas lá pelas tantas, esse paciente pode desenvolver doença valvular e como que fica a reoperação ou a cirurgia para correção dessa válvula, né? Assim, se isso traz alguma dificuldade maior ou não, porque a gente, com isso, não impede a progressão da doença valvular. Eu acho que pelo adiantado da hora, você ficar só por aqui. Muito obrigada.
Ok, Marcela, enquanto você falava aqui, eu transmiti para ele as perguntas, o Dr. Connell vai responder, então.
Thank you, Marcella. I understand the questions are, do we need to do a randomized controlled trial? And secondly, tell a little bit more information about the bicuspid aortic valve patient after PEARS has been implanted. I think, as I've mentioned just before to Rodrigo there, that the genie is really out of the bottle with the PEARS operation. This is an operation that's been going for 18 years. With the number of patients that are being done, I think that it would be unethical to actually run a randomized controlled trial. Now, some of my more senior colleagues have written about this. Professor Christoph Niembar at Brompton and Professor Tom Treasure have written about the difficulties in doing a randomized controlled trial for this type of operation. You've also got to remember that Hugh Bentall didn't do a randomized controlled trial when he started the aortic root replacement, and neither did Dr. David or Magdi Yakub whenever they did the valve sparing root replacement operations. I think that it genuinely would be quite unethical 18 years down the line after the implementation of the PEARS program to start to do a randomized controlled trial at this stage. And I think I would refer you to the very nice essay by Christoph Niembar as to why it's really not necessary or why it would be unethical, because the PEARS operation is so totally different in the vast majority of cases to a valve sparing root replacement or a Bentall operation. It's not the same as comparing apples and apples, pears and pears. It's totally different. Second question is, we do say that a PEARS application to an ascending aorta does not burn bridges to subsequent cardiac surgery. Now, I think I'm probably the only one that's actually done a PEARS reoperation where I've had to open the aorta and replace an aortic valve. And I've had to do that in 2 of my early Ross PEARS operations. I've done 48 Ross operations in my own hospital and several in different other hospitals. But 2 of my early Ross PEARS operations failed. One was a rheumatic disease process in an Afro-Caribbean patient. And I think the lesson I learned there was that rheumatic disease and Ross operations are not really compatible, because you get disease process affecting the pulmonary valve leaflets as well as the aortic valve leaflets. And a year later, I was back in doing a mechanical root replacement on this patient who was in his mid-20s. Now, at that operation, I was terrified of going back and I didn't know what to find. But in fact, it was relatively easy. The difficult bit was that the atrial appendage was really, really densely adherent to the PEARS graft, and that made dissecting out into the non-coronary cusp sinus and valve salva exceptionally difficult. And Dr. Khalil has seen how I deal with that problem now, because I reflect the atrial appendage back to well out of the way when I close the chest on a PEARS patient. But essentially, you just have to stick the knife into the PEARS, take a pair of scissors and open it up as you would do any standard hockey root type incision into the aortic root. Then you pull back the aortic root, replace the aortic valve, and then just suture up what is essentially a very strongly supported aortotomy. And I had a second patient who, unfortunately, his left coronary artery leaflet split on an internal suture underneath the left coronary artery button. And the leaflet was, as you know, very, very delicate and thin, and it just split about 6 months after cardiac surgery as it hit the internal 5-0 probing suture. And again, I replaced his aortic valve with a mechanical valve. So doing a PEARS doesn't really burn the boats for future operations. And those two identical twins that we did, I fully expect at some stage some cardiac surgeon will be back in there doing a potential valve replacement, or potentially a TAPI in the future, who knows. But it's the same as, we all do bioventals. And, when your biological inspirus valve or your perimount valve runs out, that's a technically quite a difficult, challenging operation as well. But we can do that because, we're cardiac surgeons who do complex cardiac surgery. But it's not that difficult to cut into the PEARS graft to replace the aortic valve.
Ok, thank you, Ronald. Nós estamos estourados no horário, mas nós tivemos o prazer de ter aqui de volta os nossos debatedores convidados, Eduardo Saad e Orlando Vender. Eu gostaria de prorrogar nosso encerramento por mais 7 minutos, até as 10h40, e ouvir a opinião de ambos sobre o que foi apresentado. O Eduardo abriu o microfone primeiro. Pois não, professor Eduardo, por favor.
Thank you very much, Khalil, for the invitation, and congratulations for the subject and for introducing this issue in our city here. I just want to ask and to hear the opinion. I can understand it very well, how it works in preventing the aneurysm rupture or growth. But if you could talk about the prevention of dissection, I'd like to hear some words on this subject, please.
Yeah, Eduardo, it's always a good question. It always comes up, and it wasn't in one of my slides. So there's about 3 things that people put up as being concerns. Does the graft migrate like the Florida sleeve? Well, no, it doesn't, because it becomes fully incorporated to the adventition of the aorta. Does it interfere with the function of the aortic valve? Well, no, it doesn't. And does it cause dissection in the diseased retained portion of the ascending aorta? Well, I don't know if you heard my response to Ricardo, but essentially, when does an aortic root dissect? I think an aortic root you and I have been in the operating theatre, and you're standing there watching the aorta, the heart skips a beat, and then suddenly the left ventricle has got more than the normal amount of blood into it. So the stroke volume for the next heartbeat is very, very big. And when that heart ejects, you do see the aorta do a massive big expansion. We've all seen that. It was a much bigger expansion than the normal excursion of the aorta. And I suspect that is the time when Marfan's patients or aortic roots dissect. It's during that expansion when the intima will tear. Now, if you have actually supported your aortic root, and we've shown histologically that you can get healing of the cystic medial necrosis, and I've actually cut into 2 of these aortic roots, there is an inflammatory process that holds this aortic root very, very securely by the PEARS prosthesis. So that lateral, that increase in diameter with the increased stroke volume just will not occur. And therefore you shouldn't tear the intima of your heart. The intima won't tear in diastole. I mean, that just doesn't make sense. And also, as I've said to Ricardo, there have been over 1,750 patient years of follow-up for patients who have had PEARS procedures, and to our knowledge, nowhere in the world has a patient had a dissection. So I think that we've put that argument to bed really by the duration of the follow-up of the patients that have had PEARS operations in place for more than 10, and we've got 100 patients who have had the graft in place for more than 5 years. It doesn't seem to be a problem. I mean, it was always a concern that people raised, but I think it has never been seen, and I think for the reasons I just outlined, that's why it doesn't occur.
Okay, Connell. And now I'd like to ask Dr. Orlando Vender, which comments do you have about this that was presented? And depois disso, eu pedi para o Dr. Henrique Murat também fazer uma intervenção. Orlando. Tá mudo o microfone.
Bom dia, muito obrigado pelo convite e desculpa o atraso aí, mas eu participei no início também, depois tive que trabalhar um pouquinho. Eu acho bastante interessante, definitivamente, a ideia, a gente já vem seguindo isso há mais tempo, das apresentações do Congresso Europeu, especialmente. Me parece que a grande janela para indicação seria uma indicação precoce, especialmente nos pacientes com algum distúrbio do tecido conectivo, tipo Marfan ou algo parecido. Evidentemente que ainda vai precisar de bastante estudo, mas me parece essa a grande janela. Eu sei que achei muito interessante a organização do grupo na definição e nos parâmetros para indicar essa cirurgia e a forma cuidadosa como vem se comportando nos últimos tempos. E os resultados são esses, parece que foram apresentados anteriormente. Eu acho uma excelente ideia, mas ainda, evidentemente, tem que ter um segmento melhor para a gente poder acompanhar. Mas me parece que nos pacientes com diagnóstico de Marfan ou alguma doença de colagem é uma grande ideia para se fazer a cirurgia precocemente. E, claro, a outra pergunta seria assim, mas eu vi já que tem muito pouca reoperação, mas naqueles casos poucos que tiveram reoperação, tem alguma informação do procedimento que foi feito a seguir ou não?
Olaf, is it Olaf? Yeah. Orlando, sorry, Orlando.
Excuse me, I can't listen.
Oh, tá aí.
Okay, can you hear me now, Orlando?
Okay, voltou.
That's fine. Sorry, we'd muted ourselves. Thank you very much, Orlando, for the questions. I do think that this operation should be more prophylactic than actually treating people who have got aortas that are 5 to 6 centimeters in size. I think that nowadays, when we've got a much better infrastructure amongst our cardiologists for following up people who have got Marfan's disease with aortopathy clinics, genetic clinics, we should be seeing and identifying these patients at an earlier stage in their aortic dilatation. Now, I get many patients referred to me who are female, who will be sent to me for a prophylactic PEARS before their aorta gets to 4 centimeters because they want to go on and have pregnancies. That's a very common occurrence amongst the clinicians who are looking after these patients in London and the southeast of England. I'll tell you a story. There was a patient in Brisbane who was 20 years of age who had a 48 millimeter aorta, and she was 20 weeks pregnant. And they asked me if I could go to Australia to operate on her. And unfortunately, I couldn't. So Peter Tesser, who's done about 88 PEARS operations in Brisbane, operated on this lady while she was at 22 weeks pregnant, did an off-pump PEARS on her. And it's now 18 months later, and mother and baby are doing extremely well. So that's a bit of a failure, actually, because she should never have got to that stage of a 48 millimeter aorta and getting pregnant, because apparently it was known about that she had got Marfan's disease. So I think we need to be more proactive. We need to actually do palliative early intervention. So if you've got a patient who's 16 years of age and he's got a family history of aunts, parents dissecting when they're in their early 20s, of course that child should have a prophylactic PEARS put on when they're late teenage years, when their aorta is already about 4 centimeters. And that is what is happening in London with my cardiologists. So the second question was again, Renato?
About reoperations.
Well, the reoperations that we've had to do, I've done 2 reoperations because we did have a bit of a rogue surgeon who was not putting the PEARS operation on properly. And I've reoperated on 2 of his patients. But in those patients, he hadn't dissected underneath the coronary arteries. And at reoperation, I was able to easily redissect under the coronary arteries, over the ventricular arterial junction, over the sinus of Valsalva to the VA junction. And I applied off-pump PEARS on top of the PEARS that he had put on above the coronary arteries. So I've done 2 of those. I've done 2 failed Ross operations, who I've described earlier on to Eduardo or Marcella. And those are the only ones that I've had to do. There's no doubt that there's dense adhesions, but there's dense adhesions when you're dealing with a patient who's had a Bentall or a BioBentall. And the technicality and the difficulties is no more extreme than doing a redo BioBentall. In fact, it's probably easier because the aorta is generally quite big. It's usually bigger than the 32 millimeter Dacron graft that you're trying to squeeze a 27 millimeter valve inside. And that, I think it is actually technically easier. You just open up the ascending aorta and replace the valve. It's definitely doable. We say that it doesn't burn bridges to subsequent cardiac operations on the aortic valve.
Ok, thank you, Conor. Uma última palavra, eu queria convidar o professor Henrique Moura para comentário final que queira fazer. Acho que o Henrique está aí.
Tô aqui. Espera aí, só que eu estou... Okay. It seemed to me that the case that had a mitral insufficiency and it had the PEARS operation was almost ideal because you have could avoid the dissection a long period of time. I have one question only: is this tissue that you use for the wrapping, do this tissue dilate with time? Could it dilate with time?
No, Henrik, that's a very good question. The graft will not dilate with time. The graft, I mean, it would be lovely to send you a graft so you could actually get to feel one, because I'm always very impressed by the response of cardiac surgeons when they take the graft and hold it in their own hands. This is not like a non-compliant Dacron graft that's stiff and rigid. The graft itself, I'm just holding one here. I'm not sure if you can see. It's this camera, isn't it? So this is the graft here, and this is the annular hem, and the graft over this. Which one? My camera is it? The graft over the sinus of Valsalva is quite rigid. You can't stretch that. It just doesn't stretch. It stretches a little bit in the longitudinal axis, but radially it does not stretch. Whereas if you go to the distal end of the graft, if you watch, I can stretch that quite easily. So the radial hoop strength, the strength of the graft decreases as it moves away from the sinus of Valsalva. But at the level of the sinuses where the graft is very, very strong, it does not dilate. Now, one interesting thing that might come out of this, out of the long-term follow-up of patients with PEARS on, is that if you replace the ascending aorta, like with an interposition graft above the sinotubular junction to the base of the brachiocephalic trunk, we know that if you follow those patients up, a sizable proportion of them will develop proximal arch and arch aneurysms. And that's because you're getting this pressure difference between the left ventricle, the ascending aorta in a rigid tube graft, and then that pressure is expanded as it leaves the rigid tube graft into the aortic arch, and you can get aortic arch aneurysms. Now, it was Duke Cameron, when he came to visit me in London, pointed out, he said, Conor, it'd be very interesting to see with this flexible graft at the distal end of the ascending aorta that's absorbing the energy. It'll be interesting to see if you're going to get proximal arch aneurysms. But proximally over the sinus of Valsalva, we haven't had a single patient change their aortic root more than 1 millimeter if the graft is put on properly. And to my knowledge, we've only had one rogue surgeon who has not put the grafts on properly, and I've reoperated in both of those patients. So I think it's durable. It won't change in size. I think Tal, who's sitting beside me here, is living proof every time he goes into the MRI scanner. It's his dimensions of his aortic root are identical to what they were in May 2004 when he had the graft implanted by John Pepper.
Thank you.
Ok.
Thank you, Henrique.
Obrigado, Henrique. Obrigado a todos os palestrantes. Infelizmente, a gente tem que encerrar essa atividade. Eu quero agradecer a todos os que tornaram viável esta sessão, aos nossos palestrantes, os nossos debatedores, os residentes que prepararam o caso. Eu não vou citar todos os nomes aqui para não me alongar demais e não esquecer alguém. Agradecer a SOCER, Sociedade de Cardiologia do Rio Grande do Sul, a Sociedade Gaúcha de Cirurgia Cardiovascular e a Sociedade Brasileira de Cirurgia Cardiovascular pelo apoio que tiveram para esse evento, bem como os apoios dos hospitais onde nós operamos, o Instituto de Cardiologia, o Moinhos de Vento, Divina Providência, e o Departamento de Cirurgia da Universidade Federal de Ciências da Saúde, onde eu sou professor titular e estou me aposentando, viu, Henrique? Eu passei para a tua categoria agora de ex-professor titular esta semana da universidade. Muito obrigado a todos. Até a próxima oportunidade.
Tchau.
I would just like to say congratulations to Dr. Renato Khalil and his team here at Porto Alegre on having the first patients have PEARS operation in the Americas, North and South. I think that's a great milestone and fabulous for the hospital and Renato.
Thank you very much, Carl. It was possible because of you both and Claudia.
And Claudia, yeah.
Thank you. Goodbye. Até mais.
Obrigada.
Bom dia, bom dia.
Bom dia.